Welcome to Medscape. I'm your host, Dr. Andrew Wilner. All neurologists are very familiar with the topic of headache, but today, Dr. Joshua Tobin is going to teach us something new. Dr. Tobin is a neurologist at Banner University Medicine Neurosciences Clinic in Phoenix, Arizona. Welcome, Dr. Tobin.
Pleasure to be here, Andrew.
Now, tell me how you found this case that you just reported.
I was the general neurology ward service attending in August 2023, and we were consulted for a patient who was in the medical ICU who had a headache. This is a tale of two medications, and it's also a tale of two specialties. Um, the medications are treprostinil, which is a prostacyclin analog. And this is a drug class that is very important for the management of pulmonary arterial hypertension. And it's also a tale of acetazolamide, which has absolutely nothing to do with treprostinil or prostacyclin analogs. Acetazolamide is a carbonic anhydrase inhibitor. And pulmonologists don't use it. We use it. We neurologists use it. Pulmonologists are great at helping people with pulmonary arterial hypertension. Headaches, not so much. That's not their wheelhouse. Neurologists don't ask me to manage someone with pulmonary arterial hypertension. I'll commit medical malpractice within an hour or two, if not sooner. But headaches, that is my wheelhouse. So we brought these two specialties together when the pulmonology team asked the neurology team to manage a patient's headaches. It became very clear to me very quickly that the headaches had something to do with treprostinil, and I had an idea for fixing it.
So the treprostinil is a vasodilator, right? To help the pulmonary hypertension? Is that the main way it
Treprostinil
works?
is exactly Treprostinil is a vasodilator, and that's great if you're trying to treat someone's pulmonary arterial hypertension. Not so great if you're dilating blood vessels inside the brain, increase in intracranial pressure, which if it gets high enough, it can give somebody a headache. And so since I'm a neurologist, I've been trained to ask patients lots of questions about headaches, such as, is it a pressure sensation or is it a pounding sensation? And there's a lot of details in the case report, but the two key questions that I asked her were, is it worse standing up versus lying down? And what's the pain characteristic? And she said it was much worse lying down than standing up. And she said that it was a pressure sensation. And to that, she added that the headache made her nauseated. And that's a very common migraine phenomenon, but it can also be a phenomenon of elevated intracranial pressure. And what she didn't have was light and noise sensitivity, and patients with migraine tend to have light or noise sensitivity or both. She didn't have any either of these. So this gets me to thinking, I don't think this is your run-of-the-mill migrainous headache. I think there's a good chance this is from elevated intracranial pressure. And then as we questioned her about the time course of the headache, it had started within a day of initiating treprostinil. And we know that treprostinil is a vasodilator. And well, that's great for treating pulmonary arterial hypertension, but is this dilating the blood vessels in her head?
So you gave her a trial of acetazolamide?
We gave her acetazolamide, and the first dose, the starting dose, 250 milligrams twice a day, worked great. The headache resolved completely. The oxycodone, she was taking 10 milligrams every 4 hours. They were able to cut that in half without any return of the headache.
Normally, you would use acetazolamide for idiopathic intracranial hypertension, right? A lot of us use that. It's usually in a young obese woman who has headaches and CSF pressure is increased, or for cerebral venous sinus thrombosis. How did you know she didn't have any of those things?
We went through a long list of other things this could be. We wondered if it was a mass lesion. We got a CAT scan of her head. no mass lesion. We thought about just your run-of-the-mill migrainous headache, but migrainous headaches tend to be worse standing up than lying down. Um, Her pattern was the opposite, and she didn't have any light or noise sensitivity. And then to add to that, the medication that ultimately worked, the acetazolamide, clearly lowers intracranial pressure, but it doesn't work for migraine. There's one clinical trial where they tried it and it didn't work.
There are other diagnoses that it could have been that could be something that would respond to acetazolamide. For example, glaucoma. How did you know it wasn't glaucoma?
We had a strong suspicion that it wasn't glaucoma because of the time course. There aren't any prostaglandin or prostacyclin receptors in the eyes, and her headache started within a day of starting treprostinil. And it makes sense there are prostacyclin receptors in the brain, but not in the eyeballs. It made a lot more sense that there was something taking place inside the cranial cavity, not inside the orbits.
Okay, now, way back when I was an internal medicine resident, I remember treating patients with heart disease with Iserdil and with nitroglycerin. And one of the limiting factors was both big vasodilators, and they would have headaches. And we go, yeah, you get a headache because that's just part of it, but you need it for your heart. Do you think the acetazolamide might help patients like that?
I am not in a position to see a lot of patients who have headaches from medications that are vasodilators, whether it's nitroglycerin, whether it's the PDE5 inhibitors, whether it's the prostacyclin agonist. Pulmonologists, cardiologists, they use lots of vasodilators to help patients in their specialties. And headaches are a common side effect, not just of prostacyclin analog. And I would love the opportunity to interface with these other specialties to see if medications to lower intracranial pressure, such as acetazolamide, is helpful to these patients.
And acetazolamide is available generically. It's a very inexpensive medication with a well-defined side effect profile. So I thought those would be interesting studies to do.
So this is a case report. This is one patient. She responded beautifully to acetazolamide. Her headache started within a day of starting treprostinil. It resolved within a day of starting just the starting dose of acetazolamide, 250 milligrams twice a day. Then, because she developed hypokalemia, she was taking two medications which lower potassium levels, furosemide and acetazolamide. Both of those medications were stopped. The headache returned. And you can make the argument, well, maybe the furosemide had something to do with helping her headaches because it can also lower intracranial pressure. But then the hypokalemia was brought under control. We restarted the acetazolamide, not the furosemide, and her headaches went away again. And she was ultimately able to completely come off of the oxycodone.
That's usually not an easy accomplishment. So kudos for that. Dr. Tobin, I appreciate your interest in pursuing this further. If there are physicians listening who have patients who might be suitable for clinical trial, how would they get in touch with you?
If we're lucky, maybe some enterprising medical student will, do the requisite paperwork required to do a prospective series. But let's be real, a retrospective series is far easier to do than a prospective series. And I would just love to collect cases of other patients who have suffered from headaches as a result of prostacyclin analogs or PDE5 inhibitors, things that in theory can promote vasodilation, maybe in the head, whose headaches had the characteristics of elevated intracranial pressure, and who were given medications to lower intracranial pressure. Let's test our hypothesis. Let's just not collect all the patients for whom these medications worked. If it didn't work, that's just as important also. Let's put a case series together. I don't want to dream so big that it never gets done. I'd like to keep the dreams realistic.
Sounds like a great plan. Dr. Joshua Tobin, I want to thank you very much for joining us on Medscape.
Pleasure's all mine. Thank you for having me.
I'm Dr. Andrew Wilner. Thanks for watching.